We'll move on now, and it's my pleasure to introduce John Aitken to you all. John is a pharmacist and leader of the Rural Northwest Health Community Action Research Group, and today he'll be presenting on a methodology of change for community participation in improving health outcomes. Thanks, John.
It's great to be here. Half of my talk's already disappeared today with what's been covered, so it'll mean that I'm hopefully a bit quicker. I'm a retired pharmacist. I worked in pharmacy for 25 years in Warwick, Nabil and Horsham, and I'm now doing a PhD, which is a penance probably for something else that I've done in the past, with the Trobe Rural Health School. And my PhD came out of a conference like this where the CEO of Rural Northwest Health, Catherine Morley, heard Jane Farmer from La Trobe Rural Health School talk about community participation. And for those of you that don't know, community participation is mandated by Standard 2 of the accreditation guidelines, and it's poorly done in rural health, so Catherine wanted a new methodology, to improve it. So I've got a new model of rural healthcare, and it's not a systems model. This is the Shaun the sheep model, and really I could have put a person up here, but I think a sheep is probably just as relevant, and Susan finished on sheep, so that was a lovely segue for me. And but you know, Shaun thinks he knows everything about his health, and he's out there hiding from people and hiding and developing problems and resilient, but an intervention would improve the quality of Shaun's life immeasurably, and it needs to be sustainable for Shaun to have a good, healthy outcome. So I'd like you to keep that model in the back of your mind. You've heard about Yarriambiack Shire, and perhaps Nari and I should have got together on our slides. I think that, so we are very disadvantaged, we're very big, we're very remote, we do have high levels of obesity, we do have poor male cancer outcomes. If one of my friends or I got prostate cancer, my 5-year survival rate would be 20% lower than the state average. And yet if someone gets breast cancer, their survival rate is about the same. So we don't really know the answers, obviously, to that. And I think the bottom figure always embarrasses me, not so much for my community, but for Australia, that we have a functional literacy level at 40%. And that functional literacy level feeds into things like health literacy and service literacy and other things. So we're already starting well behind the 8 ball in terms of how we can improve health and wellbeing. So my project has been community engagement to improve rural health. We used an action research framework, and we did 15 community engagement meetings over a period of about 2 years. And that involved 200 participants, and we're very much involved with co-production, so it was interesting to hear about that this morning. So we do have staff involved because we have to have realistic outcomes for our projects. We can't, and I really applaud what they're doing in Portland and Hamilton, but we're a much smaller community, and at the moment we don't have the resources to sort of move outside the boundaries of what the health service can contribute to, and that's part of our ethics framework, and I'll tell you about that in a minute. So as part of that, we've also spoken to community groups like Men's Shed and Probus and other organisations, women's groups, and the lens that I'm using is a lens called therapeutic landscape. So it's how the landscape in our community contributes to the health and wellbeing of people in the community. And to do that, we ask people to map the health places that improved their health or affected their health adversely. And the other thing we did was have a governance structure between La Trobe Rural Health School and Rural Northwest Health, and again, that's been mentioned. So this is another person who's in our team. There were 6 PhD students, 3 in different communities and 3 working on themes. And Nerida went to Canada to look at best practice, and she came across some community gardens and food co-ops, and we worked out who was important, and we've heard about ambassadors today, and we looked at who are the gatekeepers and who's not at the table. And one of the arguments is if you're not at the table, you're on the menu. So we need to get people, everybody at the table. We need their voice heard, and we need them acknowledged. So this is what happened at our meetings. We, at the community garden meeting, we looked at having a dietitian. She came along and talked about the benefits of healthy eating. As we've heard, we're in the bottom 10% of fresh food consumption in the state. And we looked at the social connectedness. That's another thing that's important for our group. So this is the structure. I'm sorry this slide's old and perhaps not as fully thought out, but it's a messy project. You don't have a ladder and you don't have a hierarchical structure, and that's deliberate. We want everybody to have equal weight in the project. You have case studies, and I'll talk about one of those. I live in the community, so you walk down the street and people say, you know, have you talked to so-and-so about their health problems? So I get people doing that. We worked with the marginalised group, the VCAL students, and we have all the other stakeholders. So we have our action research group, myself, the Rural Health School, Rural Northwest Health, the community, and finally the R&H board. And I think having a governance structure that includes the board representatives means that the board is engaged and that they can't ignore the findings, because that's one of the things that the Auditor General's report said, that boards weren't implementing the findings of community participation. So if you use an action research, and I'm the non-systems person unfortunately in this process, action research, most of you would be familiar with this. So you define your issue and you use existing data, and then you want to go out and talk to other people about what problems they have in the community. You analyse the capacity. So one of the themes of our project is to build capacity within the community, identify the stakeholders again, make sure that they're all involved and that they can participate in the intervention. Then you take your action and you're looking to see who's in control, who's determined the action, and we do use co-production, so the health service is going to have a role in that. And a governance process, because it has to be meeting the ethical requirements of Trobe Rural Health School, and it also has to meet the strategy goals of the Health Service Board. And then in our analysis and reflection, did we meet the outcomes that we were hoping for, and did we get everybody to participate? And then we go through that process again. So we've gone through that process probably 3 or 4 times as part of this research project. Someone this morning talked about having early demonstrable outcomes. So this was our early outcome, and we did our research showed that not many, I'm not allowed to use percentages, Kay tells me, so I've got to say that not many people talk to their parents and vice versa, parents talk to their children about how they're going to age in the community. Now we have a government policy that says we want people to age in the community, but we don't actually have a strategy to achieve that, and we don't have a community conversation about that. And that was one of the themes that came out of our meetings. So what we decided to do, sorry I have got 20% there, Kay, I'll have to remove that next time, is we organised what we called a retirement expo, where we got experts in aged care, in healthy ageing. We had our dietitian, we had the physios, we had some OTs. And they came along and presented data to people in our community to improve their health and wellbeing with various strategies, and to develop a community conversation about ageing. The next thing we've done is set up community gardens in 3 communities. So our other goal was to improve social connectedness and to get people eating healthy food. So community gardens was one way of doing that. We had a vacant block of land in the main street, so that became a community garden. So that improved the therapeutic landscape of our community. And we have a theme now of adding health to place. Some people have seen Judy at other presentations. Judy talked about her treatment as a cancer survivor and the problems that she'd faced, and people hadn't really appreciated the qualitative importance of some of the treatments that she got and how they affected her health and wellbeing. And now Judy's going to be on the Olivia Newton-John Advisory Committee in Horsham. Yep. So finally, just to finish off, I've focused on perhaps a very brief outline of our project. These are the challenges that we've had. I think that governance is important. I think that, you know, when you've got these multi-organisation projects, you need to get involved with various levels of governance. Are we moving too fast or too slow? That's a challenge, but you've got to do that within a framework. And how power relationships in small communities might affect it. to show that this project's 3 years old and I'm writing it up at the moment, the next phase is now we have a theme in the hospital of adding health to place. So every aspect of the hospital services will include be included within this framework. So this isn't a community garden, this is a therapeutic garden which will have sensory spaces for people, reflective spaces for people and activity spaces for people where they can undertake different community activities and hopefully socialise and work together. Thank you.